Hi guys, welcome back. We shall now be talking about a valvular lesion, that is aortic regurgitation, and I'll just zoom in the diagram so that you can appreciate the main reason why we're discussing this topic today. There is an incompetent aortic valve, so you can see the blood is racing back into the chamber of the left ventricle, which is going to contribute to a diastolic murmur. You can see the turbulence is created because of the onrush of blood back into the cavity of the LV, which normally should not be happening. I mean, in you and me, the valve leaflets coapt in a fashion that not a single drop of blood is ever able to leak back into the chamber of the left ventricle. But here, I have shown almost 50% of the blood leaking back. So that's definitely cause of concern because the pressure in the left ventricle will begin to rise. And well, God forbid, if it is an acute aortic regurgitation, patients usually die within the first 24 hours. A special event which is to be remembered for this topic and will be discussed in detail subsequently is that the blood will also hit the anterior leaflet of the mitral valve. I'll just highlight the anterior leaflet of the mitral valve. This is the anterior leaflet, mitral valve. When the blood hits this anterior leaflet, it produces vibrations of this anterior leaflet, and the vibrations which are produced will be responsible for again a development of a murmur. This murmur is one that is called as Austen-Flint murmur. So let me reiterate what I have said. I said point number one, there is going to be turbulence due to blood coming back into the chamber of the left ventricle in the early part of diastole. So you would be having a decrescendo murmur. The second thing that I'm saying is that in this patient, the blood will also go and hit the leaflet of the mitral valve, which will obviously take some time, and the vibrations which are produced of the mitral valve leaflet will be responsible for Austen-Flint murmur. So I'm talking about two murmurs there. The early diastolic, which is because of the incompetent valve, and a mid-diastolic murmur, which is because of the vibrations which are produced by the leaflet of the mitral valve and is a mid-diastolic murmur. And that is one of the main reasons why this topic is asked, because Austen-Flint murmur is not primarily due to the incompetency of the mitral valve. It is just the vibrations produced due to the onset of sudden gush of blood back into the cavity of the left ventricle due to an incompetent aortic valve. So incompetent aortic valve is resulting in a mitral valve involvement. That is why the specific name called as Austen-Flint murmur, which is one of the primary reasons, as I said, is the objective of this discussion, that murmurs is an important aspect that is asked in the exam. So we have to first understand the causes for development of aortic regurgitation, why it happens, and one of the important causes to be remembered for this topic is bicuspid aortic valve. You can see the normal aortic valve would be having cusps, and a bicuspid aortic valve, the cusps are malformed, so there's a defective coaptation. So I'll write the word BAV, which means bicuspid aortic valve. And the problem, why do you have a aortic regurgitation in the patient, is a defective coaptation of the valve leaflets. In you and me, as I said, the valve leaflets close rock solid, that not a single drop of blood is ever able to leak back. One of the important causes of acute variety of aortic regurgitation, which can cause expiry of a patient in 24 hours, is endocarditis, infective endocarditis, or subacute bacterial endocarditis. The disease process can be so fulminant that there could be a perforation of the valve leaflet, or there could be avulsion of the valve leaflet, because the bacteria would destroy the valve leaflet. So either there's a hole in the valve leaflet, or there's an avulsion of the anterior valve leaflet, or any of the valve leaflets per se of the aortic valve, and the blood that leaks back inside causes so much of increase in pressure in the chamber of the left ventricle that the backward pressure would contribute to pulmonary edema, and most patients would be having severe left ventricle failure, which is very difficult to manage because the left ventricle, the left atria, the pulmonary veins, all are congested since there's an incompetent aortic valve. Obviously, rheumatic heart disease is common in India, so obviously I'll have to say or mention regarding it, but then endocarditis component is mainly to be remembered for the acute variety of AR that will develop. Rheumatic will obviously cause a gradual onset process, so there would be scarring of the valve leaflets, and the scarring will result in, again, incompetency of the valves. The fourth reason why you could be having this is myxomatous degeneration of the valve. Do remember my statement that a topic by the name of mitral valve prolapse, MVP, there the leading cause is myxomatous degeneration, but in aortic regurgitation the causes are in the sequence that I mentioned. So myxomatous degeneration is present or responsible for both MVP and aortic regurgitation, but for MVP is a leading cause. 5 and 6 are two important respects or impacts from the MCQ perspective which are to be remembered, that is syphilis and ankylosing spondylitis. Both of these are MCQs. Syphilis anyway involves the arch of the aorta, the root of the aorta, so that's easy for you to remember. but I've explained this in rheumat section also. And ankylosing spondylitis as a disease obviously is a rheumatic disorder, but cardiovascular association can be seen. So that's again aortic regurgitation and a eccentric hypertrophy of the left ventricle that will develop in these patients due to chronic aortic regurgitation. So most of the conditions which are mentioned here would result in a chronic presentation, but when it comes to endocarditis, it's usually a acute presentation in the patient. Now, coming to the next category or the cause for aortic regurgitation, I'll just first put up a broad reason. Aortic root dilatation. If you look at the image that I have shown slightly on the left here, you will notice the fact that whenever you are having a aortic root dilatation, it will result in stretching of the aortic annulus. And due to the annulus, there would be a defective coaptation of the valve leaflets. What I'm saying is that in point number 1 to 6, the problem is in the leaflet. But now the problem is not per se in the leaflet, like they are not scarred, they're not having a perforation, they are not having any retraction, they're not having a thickening. Valve leaflets are perfect, but the annulus gets dilated. So because of the dilatation, they're not able to approximate properly, so blood can leak between the valve leaflets. Why would you be having a aortic root dilatation? One of the simple reasons for this could be aortitis, or rather more important that you can relate to is aortic dissection. Majority of patients of aortic dissection could be having connective tissue disorders or could be having uncontrolled hypertension. The number one cause for aortic dissection happens to be hypertension. So I am writing hypertension here because long-standing hypertension can cause aortic dissection that can contribute to aortic regurgitation. Point number 10, well, not very important from MCQ perspective, but still has to be remembered from the completion perspective, that the defect in the tunica media of the initial part of the root of the aorta can contribute to a disease by the name of cystic medial necrosis. And again, the aortic root dilatation, the defective coaptation would contribute to problems in the patient. Marfan syndrome is a connective tissue disorder which is associated with mitral valve prolapse, mitral regurgitation, and aortic root dilatation. In fact, one of the important reasons why patients of Marfan syndrome can die is due to aortic dissection that can contribute or be associated with acute variety of aortic regurgitation. So, two causes of aortic regurgitation of the acute variety that I've emphasized is endocarditis of either the acute variety or the subacute variety, and then even aortic dissection can contribute to acute variety of aortic regurgitation and the patient can die. Once we are aware of the causes, then we need to understand the meaning of the word severe aortic regurgitation, because most of the questions are rather focused on severe aortic regurgitation. So when would you say severe aortic regurgitation is based on the regurgitant volume? If a MCQ mentions that the regurgitant volume is more than 60 ml, that's huge, no? I mean, normally the stroke volume would be something in the range of 80 ml. If the regurgitant volume itself is exceeding when going up to 60 ml per beat, so you can understand that the forward failure will definitely occur, because whatever that goes front or in forward direction, it comes back into the heart due to the incompetency of the valve or the aortic root dilatation. A new term that is now they are mentioning in Harrison is progressive aortic regurgitation. So we need to basically have a hang of what do you mean by the word progressive aortic regurgitation. Well, it simply means that the left ventricular ejection fraction of the patient is less than 50%. That will definitely contribute to symptoms of dyspnea on exertion, orthopnea, PND, the standard pulmonary edema features that would be occurring. The left ventricular end systolic dimension should be more than 50 millimeter. And the left ventricular end diastolic dimension should be more than 65 millimeter. Now, why is the diastolic dimension increased? Because there's a blood coming back into the chamber of the left ventricle every time the heart is relaxing. So aortic regurgitation is a condition in which the preload of the heart is increased and even the afterload is increased. Afterload is increased in a sense that obviously the aorta will exhibit a resistance. Since the output is lesser, there would be a RAS system activation also. So the vasoconstriction in the peripheral circulation because of low cardiac output explains the afterload. And the preload is because the blood is coming back in the chamber of the left ventricle. So aortic regurgitation has to operate against lot of constraints. See, mitral regurgitation is a condition where the left ventricle empties into left atria, and left atria is a low pressure area. But in aortic regurgitation, the left ventricle is emptying against a resistance, and again the blood is coming back into the left ventricle of the patient. So let us actually see what is gonna happen to the ventricular cavity in the patient. Let's just look at two line diagrams here, where in the first one I'll try to represent before you the manifestations of acute variety of aortic regurgitation. Here I've shown pulmonic valve closing rock solid, and then I've shown, let me say, the leaflet has closed, but the other leaflet is avulsed, or the leaflet is damaged, or there's a perforation. So large volume of blood is racing back into the chamber of the left ventricle. Because of this large volume of blood, what's going to happen is that the whole left ventricle will get grossly dilated, and you will be having volume overloading of the left ventricle. Now this is an event that is occurring in diastole. You can see that there's no blood going out of the heart, right? This is a area when the heart is, this is the time when the heart is relaxed, and if the pressure of the left ventricle will increase, if the left ventricular diastolic pressure will increase, then even the left atrial pressure will increase. Why? Because the atria has to send blood in the ventricles during the phase of diastole. So therefore, in this patient, you would also be having congestion in the left atria of the patient. I'll repeat that again. If the left ventricular diastolic dimension and the left ventricular diastolic pressure will increase, then left atrial pressure will also increase, because it has to send blood in a forward direction. This is going to contribute to extreme amount of congestion in the pulmonary circuit of the patient, and because of this extreme congestion, most of the time, if surgery is not done, if surgical repair is not done, patients of acute variety of aortic regurgitation usually will not be able to survive beyond the first 24-hour period, how hard you try. For management of acute aortic regurgitation, we definitely use diuretics, we use vasodilators in the patient, and LMNOP, that is Lasix, morphine, nitroglycerin, oxygen positioning, would usually be just a step that might increase the survival time of the patient. But if you think that with LMNOP we are going to make this patient live, definitely not. In fact, when I discuss the treatment part, we'll discuss acute aortic regurgitation once again, but the line diagram is basically to give you an idea regarding the increase of the diastolic pressure of the left ventricle, contributing to increase in the pressure of the left atria, leading to damming of blood in the lungs, and therefore the pulmonary edema is pretty severe, or I would say the chances of mortality are very, very high. Now, let us look at the same thing once again, but with respect to the chronic version. In chronic variety of aortic regurgitation, there is obviously progression of the disease, like rheumatic will cause progressive scarring, syphilis will cause progressive scarring. So I have once again shown pulmonic valve leaflets closing very properly, but now I have shown that the aortic valve leaflets are not closing, so blood is coming back in the heart. This is going to contribute to dilatation of the left ventricle of the patient, but the dilatation is relatively lesser at the moment, in a sense that little volume of blood is initially coming back. I'm not saying that almost 50% of blood is leaking back. Let me say only 5 ml blood is coming back, but this blood, what it will do is that it will stretch the myocardium. Due to the stretching of the myocardium, there will be a development of increase in the tension generated. You see, what I'm saying is a law that you have studied in physiology classes by the name of Frank-Starling law. What does it state? It states that if you cause stretching of the myocardium, it contracts with more force. So if you upgrade the force of contraction here, that is the Frank-Starling law comes into picture, you will be having then a development of the next beat of the heart, coming with much more force. So you have a fast rising pulse in this condition. Why do you have a fast rise of the pulse? Is because the Frank-Starling law comes into picture. Every time the blood comes back in the heart, the stretching of the myocardium causes it to contract with more force, and therefore the pulse will rise very fast. It will fall also very fast, because again blood will come back. So the pulse will be a fast rising and a fast falling pulse, and this pulse is called as Corrigan's pulse, or is called as a collapsing pulse, or is called as a water hammer pulse. So the reason behind development of that can be explained by Frank-Starling law. Over a period of time, what happens in these patients is that there is a development of eccentric hypertrophy. So here I'm representing eccentric hypertrophy of the myocardium develops in patients of aortic regurgitation. In fact, patients of aortic regurgitation have one of the largest hearts. I mean, on postmortem, Harrison says that in aortic regurgitation, the chronic variety, the size of the heart can be as big as 1 kilogram. So that's huge, right? So you have a grossly eccentric hypertrophy of the heart, and this will ensure survival of the patient because eccentric hypertrophy will be able to take care, like all the impact is taken by the left ventricle. It is not passing the pressure onto the left atria in acute variety of aortic regurgitation because everything happens very suddenly. Large volume of blood, gross distension, the pressure is transmitted in a backward direction to the lungs and the person will decompensate faster. But here, because it's a gradual onset process, so the heart gets a opportunity to reply to the increasing preload, and therefore there is an eccentric hypertrophy developing in the patient. The price for that is that the demand of the oxygen consumption or the demand of the heart will also increase, oxygen consumption will increase, and there is a limited supply of the coronary arteries. If we are talking about an old age patient or even let me say a young patient who's having a bicuspid aortic valve, the problem is the consumption is increasing, but the anatomy of the coronary arteries will remain the same. Therefore, there will be a mismatch between demand and supply. I repeat my statement, the demand of the heart is more, coronary artery supply is the same, just like you and me. Therefore, there is a mismatch between demand and supply, and that mismatch between demand and supply will explain the symptom of angina, which is usually asked for this patient, because traditionally we read about angina in aortic regurgitation, but even in patients who are having presence of valvular aortic regurgitation, angina as a symptom would be present. So we need to understand two aspects here. Acute, there is a sudden decompensation, we would have a high level of mortality. Chronic, the left ventricle says, I take the responsibility, I will try to make the person survive, he will hypertrophy, he'll try to work harder, but the end result is angina manifestations would still be occurring in the patient. We shall now talk about clinical features that are encountered in patients of chronic valvular aortic regurgitation. The latency period between the onset of disease and the manifestations occurring in the patient is between 10 to 15 years. So the left ventricle is taking up all the impact. He says, okay, I am responsible. I will take all the impact of all the blood that is coming in the heart, and is gradually increasing his size. So most of the time, the symptoms that I'm talking about will take about 10 to 15 years to appear. But once the symptoms will appear, then surgery should be done within ideally 1 year of onset of symptoms. Studies have shown that if you perform surgery after 1 year of onset of symptoms in a patient, I'm talking about routine symptoms like breathlessness, exercise intolerance, angina, if the symptoms have been persistent for more than 1 year, then if the surgery is delayed, as you know, mostly in India, patients will make so many excuses, like he will say, my daughter's marriage is coming up, or some XYZ reason he'll give you to continuously delay the surgery for aortic valve repair. And if more than 1 year has passed by since the onset of routine symptoms in a patient, then the chances of recovery are reduced because the left ventricle will never come back to its normal size. If you repair the defect within 1 year, the chances of recovery is relatively faster. So there are two aspects I said. Once the symptoms take a long time to develop, but once they develop, surgery should be done ideally within 1 year of onset of symptoms. Now, what are the routine symptoms that the person would present with? First and the second symptom, they are usually not appreciated by most of the patients. When you will talk to them in retrospective, right? He came to me today with angina. He will tell me in retrospective that, doctor, for last so many years, whenever I lie down, I can feel my heart beating in my chest. So uncomfortable sensation in supine position, or he can feel his heart beating, is a symptom that is usually told in retrospective. This is because obviously, the to and the fro movement of the blood going out of the heart and coming back into the heart. So uncomfortable sensation in supine position with the ability to feel the heart rate or feel the beating of the heart is the initial presentation in the patient. The second feature that would be or can be appreciated by the patient is, like, suppose he is having sinus tachycardia due to emotion or due to coffee or tea or whatever. If the person will develop sinus tachycardia, then symptom number one will be accentuated. So sinus tachycardia, or if in old age, let me say premature ventricular contraction, then it causes worsening of the sensation of his heart being appreciated, the heartbeat being appreciated by the patient. So he will just say that I get a sensation of palpitations. So most of the time, I mean, the initial symptoms are very non-specific. And another complaint that you will notice your patient saying would be development of a pounding sensation in the head. That's again because of the to and the fro movement of the blood in and out of the heart. So therefore, head pounding sensation and heart pounding in the chest on supine position are the usual symptoms, and they tend to worsen in supine position. But most patients may not come with 1 to 3 initially. It's only in retrospective that they will start saying that, oh yeah, doctor, 5 years ago I started having this sensation in my chest, or I used to have this head pounding sensation. I thought that I'm having some kind of a migraine, or he will say that I thought I'm having some office stress. So most of the time the person or the patient might neglect these symptoms. What will definitely bring the patient to you will be development of a gradual decompensation causing a dyspnea on exertion. There might be worsening of symptoms at night, that is paroxysmal nocturnal dyspnea. On lying supine, he will say that I just feel so suffocated that I've developed a habit of sleeping with pillows behind my back. That would be orthopnea in a patient. Excessive sweating is also what is noticing for past couple of weeks or couple of months. So in these patients, the standard cardiology symptoms, once they start appearing, that is dyspnea on exertion, PND. I'm saying standard because the remaining sensations may not be appreciated by a person as maybe related to only a heartbeat. He might just say that because of stress, I've thought that, my heart is beating fast or my head is pounding. I took a painkiller tablet for that. So 1 to 3 are symptoms which are not appreciated by patients initially, but 4 and 5, he has to seek medical advice from you. That would be development of angina in these patients. The angina in these patients can be present not only on exertion but can even be present on rest. And I will say the reason for angina in these patients is primarily the increase in the oxygen demand of the heart. The tension in the ventricles is increased. There is an increased demand of the heart. So the chest pain of these patients is usually poor responsive to nitrates, though obviously that's the primary weapon that we have to fight against the angina component. But then usually we find that the response to angina with nitrates is relatively poor. So we usually have a tough time managing these patients once the deterioration has occurred. And that is why I said that once we identify the disease, surgery should be done as early as possible, preferably within 1 year of onset of symptoms, to ensure that the left ventricle tends to go back to normal size, or at least even if it does not go to normal size, at least the ejection fraction of the heart with or without medication can be maintained for him to do day-to-day activities. Let us now look at what are the examination findings in a patient of aortic regurgitation. Coming to the first examination finding of this patient, it is called as demusset sign, which would be having a head bobbing movement. Mark my words there, I did not say the word head nodding. I used the word head bobbing. This is because of the to and the fro movement of the blood, that even the to and fro movement of the head can be appreciated in the patient. The term is demusset sign. The findings that are noticed in this patient would be a head bobbing movement. That would be a to and a fro movement, primarily because of severe variety of aortic regurgitation. The second finding can be noticed in the uvula of the patient. You will ask the patient to open his mouth and you will be able to see the pulsations in the uvula. The sign or the term that we use to describe this is called as Muller sign. This is a pulsatile uvula, or I can just write the word pulsations in the uvula. In fact, pulsations in multiple organs in the body can be appreciated in these patients. And as the patient will deteriorate, you might even get pulsations in the liver, you might get pulsations in the spleen of the patient. So initially, we have the classical names coming up, that is demusset and the Muller sign. I will also look for any evidence of Marfan syndrome and ankylosing spondylitis in the patient, since these are two of the causes for development of aortic regurgitation. For Marfan syndrome, the signs that you can look for can be extremely flexible joints, then development of long fingers, that is arachnodactyly, or a development of a thumb sign. Whereas for ankylosing spondylitis, you will be mainly checking for the stiffness of the spine of the patient. So you would ask the patient to bend forward and touch his knees, and you might check for Schober's test for the ankylosing spondylitis contributing to sacroiliitis in the patient. The stiffness in the back will prevent the person from being able to bend forwards like a normal person. The next finding for this particular patient to be remembered is called as collapsing pulse. The alternative name for the same is also called as Corrigan pulse, or is also called as water hammer pulse. To appreciate this pulse, what you will do is that you will raise the arm of the patient, but before you raise the arm of the patient suddenly, what you will do is that you will use the fingers of your one hand to obliterate the radial artery of the patient. Like at the moment, what I'm doing is I'm using the fingers of my one hand to gently wrap around the wrist and feel my radial artery. Now I will put pressure with my tip of the finger to obliterate the radial artery gently, and then I will raise the arm of the patient. In a normal person, if you obliterate the radial artery and then raise the arm, the radial artery will remain obliterated only. But in this case, what happens is when you suddenly raise the arm of the patient, it is going to contribute to regurgitation of blood back into the heart of the patient because he is having incompetent aortic valve leaflets. This will result in stretching of the cavity of the left ventricle, and due to stretching of the cavity of the left ventricle, once it gets stretched, it will operate on what is called as Frank-Starling law, which says the fact that if the heart is stretched, it contracts with more force, and therefore, due to the increase in the force of contraction, the next impulse that will come will be very forceful. You had obliterated the radial artery of the patient with your fingers when the arm was by the side of the patient. Then when you suddenly raise, you will notice the fact that the pulse will suddenly come. The next impulse will come as a very forceful impulse. Why that forceful impulse, though you are putting pressure, gentle pressure with your fingertips to obliterate the radial artery, is because of the increase of force of contraction secondary to the physiological component that I spoke about, that the volume overloading results in development of increase in force of contraction. Now, a usual query, here what I get is from a lot of doctors is that then if Frank-Starling law is so powerful, then why does the heart fail? Well, there's a limit to physiology, right? I mean, there's a limit to which heart can respond physiologically. Beyond a certain limit, when the decompensation will occur in a patient, then obviously features of left ventricle failure will predominate in the patient. So the pulse of this patient is called as Corrigan pulse, or is definitely called as a water hammer pulse. The fifth feature that you encounter in this patient is called as Quincke's sign. The blanching of the skin and then a flushing of the skin that is present is referred to as Quincke's sign. So I'll just mention the name here. One, you will notice a flush. That is, the skin will appear relatively more reddish, and then it will blanch also. So this flushing and blanch that is noticed at the distal nail bed is the one that is called as Quincke's sign. The sixth feature that is encountered, sixth and seventh in fact, are because very classical names, so I'll just mention them together. One you would have read regarding pistol shot sounds in these patients. So instead of mentioning the pistol shot sounds in auscultation, I'm mentioning them here only because we can just finish the signs simultaneously. So troop sign is indicating the pistol shot sounds which can be heard over the femoral artery of the patient. The reason is same, the forward and the backward movement of the blood that is occurring in the entire circulation. Now, when you press on the femoral artery gently with your stethoscope, I said press gently on the femoral artery with your stethoscope, and you will be able to hear a to and fro murmur being heard over the femoral artery. Look at the turbulence I'm talking about, right? You are hearing something on the heart, understandable. You are hearing it over the femoral artery of the patient. That definitely indicates a significant amount of turbulence in a high pressure zone. So the finding that we're talking about is called as Durozius sign. How do you elicit the Durozius sign? Compress the femoral artery of the patient. Press on the femoral artery of the patient using your stethoscope, and you will be able to hear what is called as a to and fro murmur. Do not mix it with machinery murmur, which is found in PDA. Do not mix it with, I would say, mill wheel murmur that is found in patients of air embolism. In fact, I'll just mention it here because it's had a very classical name. Mill wheel murmur. This is found in patients of air embolism. And continuous murmur is easy, so I'm not writing it. You anyway are aware of the fact continuous murmur is found in coarctation of aorta, in arteriovenous fistula, and obviously in pediatrics in patent ductus arteriosus. So these are some of the standard signs which you can appreciate in the patient. And next we'll talk about what will happen when you record the blood pressure of this patient. The impact on the blood pressure of this patient will be in the following sense, that because in this condition stroke volume is increased, therefore the systolic blood pressure of the patient will definitely be increased. Why the stroke volume is increased is one, because of the application of Frank-Starling law. Second, there is an eccentric hypertrophy of the heart that develops in these patients in the long run. So the combination of Frank-Starling law, eccentric hypertrophy of the heart generates more force and the systolic blood pressure increases. On the other hand, the diastolic blood pressure is reduced in the patient because there's a runoff of the blood back into the heart of the patient. So if you will check the pulse pressure values will be substantially increased in these patients. Therefore, if you are going to record the blood pressure of this patient, the systolic might come as something like 160, diastolic might even come as 0. Very rare conditions would you read values of 160 by 0. One of them is aortic regurgitation. Therefore, why I'm saying 0 is because the cortical sounds might be heard right till 0 in the patient, because after all the blood is rushing back into the heart of the patient. So the actual recording of diastolic blood pressure of this patient is not that we should not wait for the cortical sounds to disappear. We should rather take that reading where the cortical sounds have become relatively muffled. Traditionally, when you record the blood pressure, when cortical sounds will disappear, that is when we say it is diastolic blood pressure. But here, you don't have to wait for the diastolic sounds to disappear. When they become muffled, that is to be taken as diastolic blood pressure. So there is a possibility that if you are taking the BP of this particular patient, because the cortical sounds will be heard right till 0, the BP might be recorded as 160 by 0. That 0 is obviously not a real recording, because as I said, the cortical sound will be heard right till the end, because this is a pathology. So in this case, you have to record the cortical sounds or take into consideration cortical sounds when they're becoming relatively muffled. But conditions where you get such kind of a outrageous value is one, arteriovenous malformation in the heart. Another one is aortic regurgitation. So two important reasons which I want you to remember. And addition of aortic dissection are conditions where you can be having such outrageously strange values given to you. And I reiterate my statement again, this is not a true value. This is actually because the cortical sound is being heard till the end. So don't wait for the cortical sounds to disappear, and rather take into consideration when the cortical sounds become muffled in the patient. Now, when you will record the BP of this particular patient of aortic regurgitation in the upper limb and the lower limb, you will definitely note a disparity. You see, in a normal individual like you and me are sitting on a chair at the movement comfortably, so the upper limb BP of yours and mine would be less than 120 by 80 millimeter of mercury, and the BP in the legs of yours and mine, because of the gravity component, the lower limb BP of yours and mine would be less than 140 by 80. So there's a difference of about 20 millimeter of mercury between the BP of the upper limb and the lower limb. That is normal for all of us. In patients of coarctation of aorta, what you can notice is that this difference, which in a normal person in upper limb and lower limb is less than 20 millimeter, this difference can be accentuated. It could be more than 20 millimeter going up to 40, maybe 60 millimeter. So lower limb BP in these patients would be rather different, in a sense that the lower limb BP could be outrageous value of 160 by 60. When I say 160 by 60, 160 is increased because of the increase of the stroke volume. The diastolic blood pressure is less, so pulse pressure is more, and the difference between the upper limb and the lower limb BP is much more than what it normally occurs in you and me, and that is called as Hill sign. This is different from what you read in coarctation of aorta. I'll just draw a line diagram for coarctation of aorta so that you can remember it here. That in coarctation of aorta, the narrowing usually occurs at the starting of the descending aorta like this. Therefore, in these patients, because less blood will go to legs, if you will record the BP in the legs of the patient, it will be substantially reduced. But because there is an increase of peripheral resistance to the aorta, if you will record in coarctation of aorta, the BP in the upper limb, the BP in the upper limb will be increased. So remember, in coarctation of aorta, reversal happens with respect to normal person. So three concepts have been described here in point number 9. In a normal person, BP in legs is more. Difference between systolic blood pressure in upper limb and lower limb is less than 20. If it is more than 20, it is Hill sign, that is a feature of aortic regurgitation. And on the other hand, if he gives you a situation where he says upper limb BP is more than lower limb BP, then it is coarctation of aorta. I repeat the facts once again. Normal individual, leg BP will be more than the upper limb BP in a sitting position, right? If you're lying supine, everything gets cancelled out because the effect of gravity will be cancelled if you're lying supine. Only in sitting position, BP in our legs is higher than that of the upper limbs by a difference of 20. If this difference is more than 20, going up to 40, 60 millimeter of mercury, we call it a Hill sign. And in coarctation of aorta, rather it is ulta or opposite, that is upper limb BP will be more than the lower limb BP. That's again a MCQ statement. In which disease upper limb BP is more than lower limb BP? Coarctation of aorta. Accentuation or difference in upper limb and lower limb BP of normal 20 millimeter higher than that, going up to 40, 60 is a feature of answer is aortic regurgitation. So that would be regarding couple of very classical signs which are encountered in this condition. So we will now look at the palpation findings that you will notice. The palpation finding of this patient would be that the apex beat of the person will be heaving. That's because of the eccentric hypertrophy of the heart that would be developing. What I mean by heaving is the impulse is forceful, it will lift up your finger. You might even be able to feel the thrill. Usually the thrill that you will feel will be diastolic, and this diastolic thrill is appreciated on the left lower sternal border. But you may even be able to appreciate a systolic thrill in the patient sometimes, because lots of time AS and AR could be coexistent also. So therefore, if you are appreciating a systolic thrill, most of the time the systolic thrill will be felt by you in the suprasternal notch of the patient. So I repeat my statement, there could be two thrills that could be appreciated in the patient. Aortic regurgitation primarily will cause a diastolic thrill, meaning a word thrill is a murmur, a palpable murmur. So you will hear it on the left lower sternal border. But if there's a coexistent aortic stenosis, or anyway the output from the heart is increased in this condition because of the increased preload, so you might have a systolic thrill that is usually felt you in the suprasternal notch, and this will be radiating to the carotid arteries of the patient. When you will auscultate the second heart sound of the patient, S2, A2 component usually is not heard. That's because of the fact that there is an incompetent leaflet. So because the leaflet does not move like normal, the A2 component is usually not heard, and therefore S2 of the patient can be single, or I can just say the word soft S2 can also be written, or A2 is usually not heard in the patient. Ejection click might be very appreciable in this patient. Why ejection click is heard is because the preload of the heart is more, so the ventricle contracts with more force. So a ejection click, a audible ejection click can be heard, especially if a person is having a bicuspid aortic valve, because bicuspid aortic valve is like a problem with both the opening as well as the closure. So because the opening is also defective and obviously it does not close properly, so the blood leaks back. So ejection click or audible can be heard in the patient. Left ventricular hypertrophy is a feature of this condition, and if left ventricular hypertrophy will occur, then left atrial hypertrophy can also occur. Atrial hypertrophy can cause a fourth heart sound in the patient. So auscultatory findings in the form of S2 that would be given would either be a soft S2 or A2 is not heard. Ejection click is audible. That's because of the increase in the preload of the heart. It contracts with more force, and a fourth heart sound due to left atrial hypertrophy. Then comes the murmur, which can be seen in the patient. The usual murmur that will be heard in this patient will be a high-pitched decrescendo murmur. Though I've discussed that separately in the murmur section, we will just have a quick look at this. If you look at this line diagram, you can see that the pulmonic valve is closing properly, but the aortic valve is not closing properly, so the blood leaks back into the heart during the phase of diastole. Therefore, when you will auscultate this patient, during the phase of diastole, that is the movement the S2 will happen, that is closure of A2, the A2 is defective in this case. The movement the A2 will happen, you will be able to hear a murmur in this patient, and this murmur is called as a early diastolic murmur. The traditional description for this is a seagull murmur. Seagull is a bird, the bird flows over your head. So when the blood flows over your head, you can hear a loud noise of the bird chirping. But as the bird goes away from you, the noise will go down. Or imagine an ambulance bypassing you. When the ambulance will come or pass just adjacent to you, loud noise of the siren of the ambulance will be heard. But as it goes away from you, the sound basically decreases in intensity. So that is what he's saying here also. Seagull murmur, or he's saying the word decrescendo murmur. That is just to represent the decreasing intensity of sound with passage of time in the patient. So traditional aortic regurgitation murmur is always a decrescendo murmur. Another feature that can be seen in this patient, and I have shown right in the starting of this lecture and I'll highlight once again, is that since the blood will leak back into the heart, it will obviously cause this seagull murmur, but the blood will also go and hit the leaflet of the mitral valve. As the blood hits the anterior leaflet of the mitral valve, the vibrations in the anterior leaflet of the mitral valve will result in development of what is called as a Austin-Flint murmur. Most of the time in the exam for this particular condition, they have asked regarding Austin-Flint, and Austin-Flint murmur is always seen with the rather severe variety of aortic regurgitation, because the more is the amount of blood coming inside, the more will be the turbulence in the patient. So Austin-Flint murmur is a mid-diastolic murmur. I'll just draw ostensible murmur before you now. The peaking of this murmur will be seen something in middle of diastole. Why? Because one, it will take some time for the blood to reach up to the mitral valve. That is one. Second, the reason for the murmur is the vibrations which are occurring in the leaflet of the valve also. So these vibrations will take some time to occur or be substantial in amount to be heard. Therefore, the finding in this patient is called as a mid-diastolic murmur, MDM. Traditionally speaking, in patients of aortic regurgitation, you can have two murmurs present. That is a early diastolic and a mid-diastolic murmur. If there is a coexistent aortic stenosis, then in these patients you could even be having a ejection systolic murmur. So do not be surprised if in a question he mentions regarding a ejection systolic murmur in this patient also. This is lots of time present if there is a coexistent aortic stenosis or a bicuspid aortic valve in a patient. So three murmurs could be given in the question. Let's revise them. The main murmur of the lesion is early diastolic murmur. That's as soon as the blood leaks back into the chamber of the left ventricle, there is a turbulence. The time it takes for the blood to reach up to the mitral valve, there would be some time lag. Then the vibrations of the mitral valve, that will result in the second murmur of this patient, that is called as a ostensible murmur. And if there is a coexistent aortic stenosis, the ejection systolic murmur can also be present in the patient. I have today talked about Troop sign. Troop sign is characterized by pistol shot sounds. Do not mistake it with troop space. I'll just put an image here for troop space. Troop space is basically to evaluate for splenomegaly in a patient. So troop space is an area which would be present on the left side of the stomach. That's where the spleen is usually checked. So just as a matter of fact, because the words are similar matching, troop sign, I am saying again, is for aortic regurgitation, and troop space is mainly to check for the presence of splenomegaly, which could be secondary to endocarditis or any particular reason developing in this patient. And incidence of endocarditis in these persons is high because the high pressure gradient contributes to increase incidence of development of infection in the heart of these patients. Now we will study some atypical names for this particular condition. The first atypical name to be remembered for these patients is pulsations in the spleen of the patient, that is called as Gerhardt sign. So pulsatile spleen or pulsations in the spleen are found in aortic regurgitation. The next one is Rosenbach sign. This is with respect to pulsations in the liver of the patient. Do remember the fact that when I've taught you about tricuspid regurgitation and tricuspid stenosis, even then I have talked about pulsations in the liver. So I've talked about three diseases where pulsations in the liver can be felt. That is tricuspid stenosis, which is usually pre-systolic pulsations. Tricuspid regurgitation, which is systolic pulsations. TR operates during systole, no, so systolic pulsation. TS is pre-systolic pulsation. And now I'm telling you, even aortic regurgitation can be having a development of pulsations in the liver. At this junction, I also want to warn you that do not mistake this Rosenbach sign with Rosenbach sign of Graves' disease. So Rosenbach sign with respect to the eye is a feature that is seen with Graves' disease. What are the manifestations of Rosenbach sign would be presence of eyelid tremors, which can be appreciated even when the eyes are closed in the patient. So do remember, Graves' disease has Rosenbach sign, that is called as Rosenbach sign of the eye, eyelid tremors, and Rosenbach sign in cardiology is with respect to pulsations of the liver. The next feature of this patient would be pulsations which can be seen even in the pupil of the patient. This would be called as Landolfi sign. This is, however, of only historical importance because most of the time nowadays people tend to seek advice earlier. You see, in earlier times when treatment processes were not very well organized and rheumatic heart disease was so prevalent that people used to develop severe MR, severe aortic regurgitation. Now to get a patient of severe MR, severe AR is like an annual event. So most of the time these findings are not seen or read only in textbooks, but because they're given, we need to remember Gerhardt for spleen, Rosenbach for liver, not to confuse with that of Graves' disease, and lastly Landolfi sign, which would be pulsations in the pupil of the patient. So I'll just write it for the sake of completion so that you don't forget it. Pulsations that would be noticed in the pupil of the patient, or pulsatile pupil, could be a feature, not like hip pus, right? That's a totally different aspect I'm talking about. Hip pus is seen with like aconite poisoning, but here I'm talking about pulsations of the pupil, which are mainly because of the valvular insufficiency and the to and the fro movement of the blood, which is responsible for these manifestations. We will now study regarding what are the treatment protocols for management of this condition. So let's now look at management of acute aortic regurgitation and chronic aortic regurgitation. To manage these patients effectively, therefore, we need to do a quick workup of these patients so that we can plan out the best possible strategy. The investigational choice for this person is obviously echocardiography, because that's the standard answer for all valvular lesions. But here I'm just saying that the first investigations that I would like to do in this cardiology case, because he came to me with chest pain and breathlessness, would be a ECG. Let us just practice some aspects of ECG in this patient as well. So whenever you are given a ECG in the exam, the first option or the first thing that you should do is have a quick look at the heart rate of the patient. If you see this ECG, you will notice the fact that there are approximately reaching up to 5 large squares separating the R and the R intervals. So the heart rate of the patient will be 300 divided by 5. That is something in the range of 60 per minute. That is pretty normal. Then we will calculate the axis of the patient, and for calculating the axis, you need to look at the data in lead number 1 and data in lead number AVF. Let's now see data for lead number 1. You will notice the fact that in lead number 1 of this person, the R wave is taller than the S wave. So I'm putting a plus sign here because the R wave is more than the number of the squares of the S, so it's a positive vector. However, when you look at AVF, you will notice the fact that the S wave in the patient, in this case, is deeper than the R. So mathematically speaking, R minus S in lead number AVF will turn out to be negative. Why? Because S depth is more than that of the R. When I plot the negative vector here with respect to lead number AVF, and if I join the two, the axis of this person will come as left axis deviation. So now the findings in the ECG is heart rate turning out to be close to 60 with left axis deviation. When you scan the ECG, then subsequently you are noticing that some of the complexes are so huge, the R waves are so huge that they're spilling out of the ECG paper. Anyway, I'm having a hint that this is a left axis deviation, so I will apply a rule here. The rule to be remembered for the patient is SV1 and RV5 V6. What that means is that you will look at the depth of the S in V1 and the height of the R in V5 V6. If that goes more than 35 millimeter, that is more than 35 boxes, it indicates that there is a left ventricular hypertrophy in the patient. Now, if you look at lead number V1 of this patient, if I zoom it in lead number V1, you will notice the fact that the S wave is substantially deep. So I'll just do a counting here. That is about 1, 2, and 3 large squares in the patient. 3 large squares would mean 15. And if you look at the height of the R wave with respect to V5, that's substantially tall. So let me just do counting here also. That would be approximately about 5 more large squares. So if I add up the two, it's total of 8 large squares. 8 into 5 would be 40. So the hypertrophy of the patient is definitely present. I can count approximately 15 millimeter of depth with respect to the S wave in V1. I can count up to approximately 25 millimeter of the vertical height of the R wave in V5. So since the sum adds to be 40 millimeter, that's definitely a feature of left ventricular hypertrophy in the patient. Then you will also notice that the patient is having presence of T wave inversion. The T wave inversion is primarily because of the subendocardial ischemia in this patient. Though the T wave is scattered, but still it is very much present. The T wave inversion is pretty substantial in most of the leads of this particular patient. So I'll summarize what I said. 1, the patient is having left axis deviation that talks about left chamber enlargement, left ventricular hypertrophy is present, and left ventricular strain. Left ventricular strain simply means that there should be demonstration of T wave inversion in the patient, mostly in the chest leads of the patient, because we're talking about the left ventricle, so chest leads would be showing a T wave inversion. So all these indicate a chamber enlargement in the patient. Obviously, the investigational choice for this is echocardiography. When do you say severe variety of aortic regurgitation? Because severe is where a priority basis surgery is required for the patient in the form of a valvular aortic valve replacement. For diagnosis of severe aortic regurgitation, the first and the foremost criteria to be remembered is with respect to the width of the regurgitant jet of blood. You can measure the width with respect to Doppler, and if the jet of blood is having a width more than 65% of the left ventricle outflow tract, it indicates severe aortic regurgitation. The most important criteria which he can ask you is what I have already mentioned in the starting of this discussion, that is regurgitant volume of more than 60 ml per beat. Or instead of saying regurgitant volume, he can write the word regurgitant fraction of more than 50%. Even if you don't remember these three facts, it is still okay, because most of the time he will himself say the word severe aortic regurgitation because he wants to talk about treatment, and treatment is very straightforward: symptomatic aortic valve replacement, severe variety, asymptomatic patients also. If it is severe, then aortic valve replacement is now recommended for the patient. Though earlier the concept was, we know we should wait for the person of severe variety to become symptomatic, but now he says that in the severe variety also it is advisable to go in for a AVR in the patient. If you will do a chest X-ray in the patient, it will substantially show a left ventricular enlargement. So whenever there is a left ventricular enlargement, the apex of the heart tends to be displaced inferolaterally. If there is a right ventricular enlargement, the apex of the heart is pushed laterally but superiorly, so there is a upturning of the apex of the heart. But if you look at this X-ray, you can see the prominence of the left heart border, especially with respect to the left ventricle, and the apex has been pushed rather inferolaterally. If you look at the surface marking in the heart of this patient, this is the aortic knuckle, which also looks relatively prominent in the patient. Inferior to that is the area of the pulmonary artery. Inferior to that is the area of left atrial appendage. This is LAA, left atrial appendage. But below the left atrial appendage, you can see a marked convexity with respect to the enlargement of the size of the left ventricle of this particular patient. The right heart border looks fairly decent. So considering the X-ray of this patient, as I have highlighted, the finding in this person to be remembered would be a prominent left ventricle with the apex which is displaced inferolaterally. Considering the fact that a lot of patients could be having angina manifestations, and if this occurs in relatively old age, then you could be having a concomitant coronary artery disease also. So coronary angiography is basically to know regarding the status of the coronaries of the patient. A lot of these patients might have to undergo a coronary artery bypass grafting also simultaneously. Then obviously the intraoperative mortality tends to increase, because obviously as you increase the number of procedures, then especially operating an aortic valve is itself a big challenge. With coronary artery bypass grafting, the intraoperative mortality rate will increase. So that obviously has to be kept in mind by the cardiothoracic vascular surgeon. Now once you identified that there is a problem in the patient on the basis of the clinical features that I have mentioned, and then with respect to the investigations, we will look at what will we do for management of this patient. For acute aortic regurgitation, which will be having a severe pulmonary edema, the first line drug that you will use would obviously be a loop diuretic. Along with this, we will be using a vasodilator in the patient. The vasodilator that is recommended for acute aortic regurgitation is sodium nitroprusside. Now that is a little surprising, because normally sodium nitroprusside is recommended for hypertensive emergencies, but as I've explained, this is a disease where the heart is operating against an increased afterload, because after all the output is less, so the peripheral vasoconstriction will increase. That will put more stress on the heart of the patient. So sodium nitroprusside is a vasodilator which is recommended for these patients to reduce the load and ensure a better functioning of the left ventricle. Obviously surgical management should be done in the first 24 hours, failing which usually mortality can occur in this patient, because the pulmonary edema can be catastrophic. If he says person is having chronic variety of aortic regurgitation, again the first step in management of the patient is diuretics. Along with this, we definitely have a role with respect to ACE inhibitors and calcium channel blockers, because they would be reducing the afterload on the heart. The main objective is to keep the systolic blood pressure of this patient less than 40, and that is really difficult. Why? Because if hypertension occurs due to increased renin, then ACE inhibitors are very good. But in these patients, the increased systolic blood pressure of the patient is due to increase in the stroke volume of the heart. And this increase in the stroke volume is operating secondary to the Frank-Starling law, that the blood comes back into the heart, the ventricle contracts with more force. So the stroke volume is increased, one due to Frank-Starling, secondly because of the eccentric hypertrophy, which I've been talking right since the beginning of the discussion, contributes to increase in the stroke volume. So since you see blood pressure is a formula of cardiac output multiplied by peripheral resistance. ACE inhibitors are very good if the problem is in the peripheral resistance alone, but here the problem in the patient is both peripheral resistance is upgraded, and in these patients there is an increase in cardiac output due to increase in stroke volume. The peripheral resistance is upgraded because obviously the perfusion of the organs like kidney etc. is getting compromised in the patient, but the increase of stroke volume contributes to upgrade of the systolic blood pressure. So objective is to keep it usually less than 140 because you will be able to reduce the afterload. I would like to reiterate my statement once again. Mitral regurgitation, the left ventricle empties into a low pressure circuit, LA, left atrium. Here, the left ventricle is emptying into aorta, which is a high pressure circuit. So both of them are hemodynamically important, and aortic regurgitation is more stressful for the heart because you see, emptying into a low pressure chamber, emptying into a high pressure chamber, the more load will be when you empty into a high pressure chamber. So aortic regurgitation on a comparison basis, I mean obviously any heart disease is debilitating, but on a comparison basis, if I select MR versus AR, then I can say that AR is gonna put more load on the heart per se. The eccentric hypertrophy of the heart will also bring in the increase in angina component. For management of the angina component, it is nitrates which are to be used. Then can be mention of some miscellaneous aspects like penicillin, because syphilis can be a cause for development of aortic regurgitation. The penicillin that would be used if it is a cardiovascular syphilis is benzathine penicillin. They rather asked that what is the treatment for cardiovascular syphilis, that is benzathine penicillin. The injections would be given of 2.4 million units intramuscularly. There would be a total of 3 shots which would be given to the patient at a gap of 1 week each. So you will have to give total of 7.2 million units of benzathine penicillin to the patient. Do remember, for primary syphilis we give single dose, but for cardiovascular penicillin, cardiovascular syphilis, we give 3 shots. And if it is neurosyphilis, then we give penicillin G intravenously for duration of total of 2 weeks. So I repeat my statement: penicillin, benzathine penicillin for primary syphilis, benzathine penicillin for cardiovascular syphilis, 3 shots, total is 7.2 million units. And lastly, I said that if it is neurosyphilis, then we use penicillin G intravenously for 2 weeks. What is the role of beta blockers in aortic regurgitation? Well, first of all, remember the fact that beta blockers are absolutely contraindicated in acute variety of aortic regurgitation. Why? Because beta blockers are not given in acute heart failure. In fact, beta blockers and intra-aortic balloon pump both are contraindicated in patients of aortic regurgitation, primarily because one, beta blockers are not given in heart failure. I said already, intra-aortic balloon pump will worsen the lesion of aortic regurgitation. So do remember this aspect: beta blockers are not to be given in acute variety. For the chronic variety, I'll say like this: when I was a student at your age, they used to say beta blockers are contraindicated in chronic also. The logic behind that was that when beta blockers will slow down the heart, it will result in increase in the duration of diastole, and that will cause, or it will give more time for the blood to come back in the heart. The logic was that why we don't give beta blockers was slowing down the heart will cause the increase in the duration of diastole, so it will be more blood coming back in the chamber of the heart. But this theory is now discredited in a sense that he says yes, I mean diastole duration will increase, more blood will come back in the heart, but at the same time the beneficial effects of beta blocker would be that they will reduce the oxygen consumption of the heart as well. So the current concept is that beta blockers can be used in chronic variety. Obviously, he says under close supervision, because if it's decompensating to acute, you have to stop beta blockers. But I would like to make I would call it an update, because at your age, when I was studying beta blockers never given in chronic aortic regurgitation, but now the concept has changed with respect to beta blockers being recommended for chronic because of the functional benefit with respect to reduction in the oxygen consumption of the heart of the patient. For the treatment of choice for this patient, the treatment of choice is going to be answered as AVR, aortic valve replacement. This is the best way to treat a patient of severe aortic regurgitation who's symptomatic. And another update that I can mention towards the end is that at your age, I used to study that in asymptomatic patients don't operate. But now for severe variety, though it looks very highly unplausible, no, severe AR asymptomatic, but yeah, human body has great powers of I would say fighting back the disease. So if a person is asymptomatic, we will not let him suffer, but we will rather operate on the patient as early as possible. If it is mild to moderate AR in a patient, if the symptoms are developing in a patient, again aortic valve replacement is recommended. Why they are saying it is recommended, and the timing of surgery is also important. That once the person is decompensating, once he is becoming symptomatic, operate within the first year of onset of symptoms. The reason for that is that recovery is usually possible in the first 1 year only. That the heart can come back to its normal size, then even if it does not come back, at least the cardiac output will remain substantial enough for a person to go about his daily activities. So AVR is the treatment of choice for this patient. This is the management strategy that we use. From MCQ perspective, most of the time they will rather ask you regarding what is not to be done in acute aortic regurgitation. So intra-aortic balloon pump and beta blockers are not recommended. So keep working, guys, keep hammering, and I'm very sure you'll come up with flying results. And this is one topic which is both asked in university as well as asked in entrance exams also. So a careful listening of this is recommended. Thank you so much for listening.